See if this works. Yes. Good morning, everybody. Thank you, Luis, although Luis is not there, for the invitation. So let's see if this works. I need my glasses. Yeah, so neurointervention is, of course, about using a lot of tools, and we liked it. And but even the most simple tools can have some unexpected adverse events and cause damage to precious things. So, and this talk is about the same issue, that it's about flow diverters in acutely ruptured aneurysms. So lots of the work was done by Michelle ten Brink. Oh, you can see here. So that's a student of us, and she did a lot of work on this. These are my disclosures. So we also did, basically she did most of the work, that the meta-analysis and a systematic review on flow diverter use in ruptured aneurysms. And I learned a lot of that because if you go systematic, go through all the literature, as was discussed many times already this morning, that the scientific evidence is very bad. So we found, we did a pretty strict selection. We only selected studies more than 5, that described more than 5 cases, which is very few. We end up with only 17 studies. Actually, only 2 studies, and we had a third one, had more than 10 cases. So there's hardly any useful paper written on this, and everybody does that probably, and we don't know the results. So I was a little bit shocked about this result. So this is the study design. So we asked a couple of other centers, most in the northwest of Europe, one in the US, and so to report their results. Flow diverter use within 15 days, so really in the acute stage. These are the centers. So we built an eCRF, easy to use, so web-based CRF, so where they could enter all the data. Some case illustrations. A very old lady sent from another neurointervention center. They said, well, we cannot treat this. And this is a very, we also discussed that early this morning, what kind of aneurysm is this? It's definitely not a normal secular aneurysm, it's exactly at the bifurcation. So what can you do? So this is technically, as discussed, this is not difficult to use, even in an 88-year-old patient, to put a flow diverter, and this patient did well. Maybe we were lucky, I don't know, especially she was lucky, of course. Another case, this is kind of a blowout of an M1. Difficult, what can you do? So here we said it was a young patient. So we do jailing, both flow diverter and coiling. We are a little bit concerned about striates, of course, the fit of the striate. We thought there were no other good options. So here, flow diverter and then coiling, not too dense. So it was a little bit also watching, of course, the lenticule striates. Unfortunately, he had a tiny infarction, a lacunar infarction, but he did pretty well. Also a young lady, and this was also a strange, not standard aneurysm. We have a little bit the impression that it's maybe partially thrombosed, according to the anatomy. So we could enter it with a wire. We wanted to coil that, didn't work. We tried everything. We even found a contralateral approach and tried with a catheter and a wire to get it in. So it didn't work. So we said, okay, then we do a flow diverter, which also worked. But it's not always big fun, because now I showed good cases, but that's here's another one that went, that did not a good result. Very complex aneurysm by means of, we were not able really good to visualize, is this only an A1 aneurysm, or is this also involving the ACOM? So we did double injections, etc. But because we were not sure, we said, okay, we're gonna put a flow diverter from the ipsilateral A1 to the ipsilateral A2. You see also here there's a very slow filling, and you see that on the right image, slow filling of that A2. So it was difficult to visualize, but finally that worked, and we coiled it not very densely. So this is the, so we needed 2 flow diverters, and it landed exactly at the proximal part of the A1. So that looked pretty okay. And then we put some coils, and basically after the end of the procedure, it looked not too bad. And unfortunately, so this patient did well the first week, so the first 10 days, and then there was a rebleed. The EVD was full of blood. There was a clinical deterioration in the acute moment, and you see there recurrent aneurysms. So it took us quite a time to find out what was wrong, but basically what happened, there was a migration of the proximal flow diverter towards distal and was more or less into the sac. So that didn't work. So we tried to enter that to reconstruct the artery, but it didn't work. So finally we ended up by occluding the artery. We also saw a lot of vasospasm, and the patient kept on deteriorating with ischemia and succumbed, died a couple of days later. So these are the patients. All kinds of aneurysm, not only fusiform but dissecting, and all kinds of flow diverters. Half of them were in the posterior circulation, and also a couple of them, but not that much, were coiled, only 1/5. So basically, what's interesting in the results, well, the clinical outcome, of course, half had a good outcome. That has to do, of course, with the subarachnoid hemorrhage, of course. But what may be interesting is that the angiographic result was pretty okay on those patients that survived and had angio follow-up. But what really was a problem is that half of the patients had intervention-related complications. And we, before we did this study, we thought, well, okay, flow diversion works. It's not easy. It's not difficult, so we can do it. I was rather shocked by these results. That if you look really strict, and you have like more or less independent reviewers, because the neurosurgical resident, they score all the complications in the files, of course. So that half of the patient had complications, not always severe complications, but they were there. But there was also pretty annoying rebleed rate of 11%, and so you end up with this series of 44 patients with more than a quarter that have a permanent neurological deficit caused by the intervention. So that's not that good as I would have expected. And of course, here related for unfavorable clinical outcome is of course the high WFNS grade. That has to do with the bleeding, and of course the intervention-related complications. So in conclusion, they work, of course, flow diverter for acute cases, but there's a high overall complication rate, period procedural, with like 27% of the cases that have a permanent deficit that you cause by your action. And what he also find that those cases that had a rebleed, that were the larger aneurysms that had a rebleed, and we think, but that was not statistically significant, that if you put coils, you protect for a rebleed. So I would advise to do that. But for us, it changed a little bit our strategy, that we are a little bit more reluctant and try all the other standard options and do it only as a last resort treatment. So that's it. Shall I proceed with the next talk?